this title is way too long, but so it's about subacute and chronic low back pain. We did a review of prognosis in acute low back pain, and we did a workshop on that systematic review in Manitoba. That the funder of that review and our stakeholders actually more or less indicated that they were interested in extending that systematic review by including the subacute and the chronic phase, and see what kind of prognostic factors were known in subacute and chronic low back pain. And it's all about time away from work or sick leave or disability benefits. So on the team are Claire Munhall, Nelson Aranya, and Stephen Passmore, who are in Manitoba. Emma Irvin is here, Kwame Mahout from the Institute, Dwayne Van Eert from the Institute, and Sheila Hawk Johnson. So this study was funded by the Workers' Compensation Board of Manitoba, and we collaborated with the University of Manitoba on this, we're collaborating with the University of Manitoba on this project. So this is the Institute for Work and Health. It's a not-for-profit research organization. We conduct and share research to protect and improve the health of working people, and this study fits in with the second bullet point. It's about improving the health and recovery of injured workers through research on treatment, return to work, disability prevention and management. And in this project we explicitly involve a lot of stakeholders in the process. So the goals for the plenary is, so we want to share some research finding on this topic, and we would also like to get your feedback on the findings, because it's important on how to share those findings in the future with our stakeholders. It's building on a presentation that we gave in Manitoba, with a full workshop and an interactive exercise as part of the workshop. So you might find some remnants of that workshop. And the remnants are actually on the table, so we'll get back to that a little bit later. In this plenary, I will give an overview of the methods that we used, shortly brief you on what we did in Manitoba, present the results of the systematic review, and elaborate a little bit on the next steps in this project. So these are still somewhat preliminary results, because it seems like every time I go back into the data, I find some new things, but I think we're settling in now. So, but there might be some room for improvement based on feedback that we get from you. So this is an interview of the published literature. So don't shoot the messenger if you don't find what you're looking for. This is what we found in the literature. So overview of the methods. So the rationale of doing a systematic review on prognosis is that prognosis is important to identify high-risk cases that will likely benefit from earlier intervention. At least that's my assumption. Why we do a systematic review is the amount of information from the scientific literature can be quite overwhelming to end users. And as you will see in this presentation, it can also be quite overwhelming for people that are scientists and are supposed to be totally familiar with all the methods involved. So this is an extension of a systematic review on return to work in acute low back pain, and it's summarized the evidence on return to work in subacute and chronic low back pain. But I am also referring to some of the results that we had from the previous review. So in a systematic review, it's like a regular study. We develop a question, we do a literature search, identify relevant publications, praise the quality of these studies, and because it's about prognosis, those studies are actually praised. The quality appraisal of that type of study is actually something that we had to do a little bit of development on. We extracted the data, and then finally we came to the evidence synthesis step. It's a topic where a lot of different stakeholders are involved. So we wanted to look at factors that play in the workplace, that are present in healthcare services and within the insurer or the Workers' Compensation Board, and factors that are present within the worker and patient. So we wanted to look at it from different angles. So why is prognostic information important? Clinicians commonly use prognostic information to educate their patients, to target specific factors to be modified through intervention, and most of all, communicating about prognosis, whether people have a good prognosis or a bad prognosis, is very important to reassure their patients so they don't get crazy ideas about where they're going to be ending up, because most of the times it is about reassurance. Insurers also often try to identify low and high risk cases in their approaches, and workplaces want to know how long it's going to take before a worker gets back to work, because they might actually have to hire replacements to do the job of the injured workers. So they're all interested, and they all have a slightly different viewpoint. So prognostic information, in my view, can be used by insurers and workplaces to engage in work disability prevention. So we want to assess the evidence on factors that predict time away from work. So our first hypothesis is that there are factors related to the different stakeholders, to the worker, to the job, the psychosocial environment that influence that duration. And we hypothesize that in the chronic phase and in the subacute phase, that psychological and social issues might be more prominent compared to what we see in the acute phase. And what we in the end want to try to develop is some kind of an evidence-based handbook that could support return to work practices in the province of Manitoba, because that's where the funder is. So we searched three major databases. This is the boring part, unless you're interested in systematic reviews, of course. But it's Medline, Embase, and PsycInfo. Two reviewers independently reviewed all titles and abstracts, the full articles of those that made it through the title and abstract screening. And if we weren't totally clear in the full article phase, we actually tried to contact authors of the publications to get some clarification. So we were looking for studies that looked at an episode of low back pain and sick leave or time on benefits. So the duration had to be, in this systematic review, more than 6 weeks. So people had to be off work for more than 6 weeks at the moment they entered the study. We had to have at least one prognostic factor and return to work as an outcome. It sounds obvious, but there's a lot of descriptive studies out there that we, by using that inclusion criteria, could exclude. And we wanted to have studies that measured the association with the outcome in absolute terms. So we needed to get some quantitative information that we could actually summarize at the end. So we're looking at populations that are at risk for return to work, which implies that they still have to have a job they can return to. So people that have chronic low back pain, but that have been laid off or lost their job in the process. We think that that's a very different population. So we wanted to focus on those that actually still have a job that they can return to, so they're considered at risk for return to work. So that's also a specific. So why did we use that 6-week cutoff? So in the first systematic review, we looked at the acute phase, which means following the John Frank and Sheila Johnson curve on return to work or time on disability benefits. In the acute phase, we looked at studies that were in the first 6 weeks of time off work, and in this case we looked at beyond 6 weeks, which is considered to be the subacute and the chronic phase, because the idea is that in the first 4 weeks, actually 50% of all cases actually get back to work, and after that it's getting a little bit more problematic, and that's where the categorization between acute, subacute, and chronic low back pain stems from. So we looked at the acute phase, and now we're focusing on the subacute and the chronic phase, assuming that those patients can be quite different. So we did a quality assessment where 2 reviewers independently scored the quality of included studies on 21 items in 6 categories. So we looked at the description of the population, we looked at information on response rates, information on follow-up, so how many people were actually followed up over the course of the study. Whether there was a definition of the outcome, because it's often lacking or very rudimentary, so there's a lot of guessing that you have to do when you read those papers. We wanted to see a look at the quality of how those prognostic factors were actually measured. Is it a well-established measure? Is it validated and tested for reliability? Or is it just something that they found in the database and more or less plunked into their study? And we wanted to look at how they present the data, whether there's actually a good presentation of the data, so that we actually have information that we can use in our systematic review. But this is all about reporting of the study, which is always a bit tricky because it doesn't mean that it's a low-quality study. It's just sometimes it's really a shame that they reported it this way, because it seems a really valuable study, but they just reported it in a way that we can't really use the data that they presented. So we used totally arbitrary cutoff points where we said, well, if you have 16 to 21 points, you're a high-quality study. If you score 13 to 16 points, it's a moderate quality study. And lower than 13 is a lower quality study. Then we said, okay, we want to summarize the evidence. So we consider strong evidence when there's consistent findings in multiple high-quality studies. There's moderate evidence when there's consistent findings in at least one high-quality study, or in one high-quality study and one or more lower-quality studies, or in multiple lower-quality studies. And there's insufficient evidence when there's only one study available, or when there's inconsistent findings in multiple studies. So what we did in Manitoba last month, we went to Manitoba. What we asked stakeholders that we invited to 2 workshops to sort prognostic factors and actually stick them on the posters that you see in front of you, and tell us what they consider to be important prognostic factors, either in the acute phase, in the subacute phase, and chronic phase. So we gave them a selection of the factors that we identified in our systematic review, but we left it open. They could also tell us what they found important if they didn't find those factors in the cards or the stickers that we provided. In those little working groups, they discussed each factor and how they might differ between the acute and the subacute and the chronic phase. We had people from mixed backgrounds in those groups, so they could be an injured worker advocate discussing issues with somebody that works at the Workers' Compensation Board in Manitoba. And what was quite interesting is that we actually we got a lot of people from insurance companies, so a lot of people that have experience in short-term disability and long-term disability, and we had a lot of healthcare providers in our workshops. They presented the results, they presented the group findings, so we let them present to us what they found important and how they found it important, and created a discussion. After those working groups, we presented the results of the review that we found, and after the fact we could discuss some discrepancies between what they reported to us and what we found in the literature, which was quite interesting. Presentations and some in-group discussions were recorded, and those recordings will be analyzed so we can have a thorough understanding of what people find important in Manitoba and how it compares to what we found in our workshop, so we can actually present a story that makes sense to people in Manitoba. So these are the sheets that you find in front of you as well. So what kind of stood out is that I'll just point. So this is the third group in the morning session said that job satisfaction was important in all phases. They found that kinesiophobia, so fear of movement, was important in all phases. Workplace physical factors they thought was mainly important in the subacute phase. I'm just highlighting some of the findings that I know that we'll be coming back to later. They reported that expectations of return to work were really important in the chronic phase. This is the third group in the afternoon, yeah. Functional status, so how people function moving around, is important in the acute phase, they said, but they didn't report it in the subacute phase or in the chronic phase. But they did say that the functional capacity evaluation is actually important in the chronic phase. And again, job satisfaction in the acute phase, in the subacute phase, but not in the chronic phase. Third group is, so they report that general health is important in the acute phase and in the chronic phase. Job satisfaction here and job satisfaction here, but not in the chronic phase. So they really concluded that there is actually there are different that there might be different factors important in the different phases. So the longer people are away from work, other factors might actually play a role. So what did we find in the systematic review? This is about the amount of studies that we found. Thank God for digital copies. So what we found we found 5,000 papers that were potentially relevant based on the search criteria. 939 papers were retrieved for further evaluation. We found 144 studies that seemed relevant, but we excluded some clear intervention studies, some surgical studies, languages that we couldn't understand, and we couldn't get somebody to actually read it for us. And we also excluded some systematic reviews. They're in our, we keep them as a reference, but they're not part of the further process. So we had 78 papers, 12 were considered to be lower quality, 30 had moderate quality, and 36 had a high quality of reporting. In the end, we found 16 papers that were in the chronic phase, 6 in the subacute phase, and 37 in the acute phase, but they were already part of the earlier process, and we found a few new studies actually in that phase. And there were 19 where either they had workers from different phases in one study, so they had chronic cases, subacute cases, and acute cases, or they just didn't report how long people were away from work, so we couldn't really use this group of papers in our synthesis because we were interested in differences between the phases. So 78, so 16 chronic, 6 subacute, 37 acute. Studies came from Australia, Greece, New Zealand. Actually, quite a few from Canada, 21, especially when compared to the previous search that we did. Mean quality was around 16. So when we compare that to the search that we did on the acute low back pain studies, so we now found 21 Canadian studies, but in the acute phase we only found 3 Canadian studies. So there seems to be big interest in the later phase of work disability in Canada. So in the acute phase we found 204 different prognostic factors. And if you look at the subacute and the chronic phase, there were 482 different factors reported. So that's kind of confusing. There's clearly no agreement between researchers. So the levels of evidence, from now on, everything that's in green indicates strong evidence. So there's consistent findings in multiple high-quality studies. Moderate evidence is in yellow. Consistent findings in 1 high-quality study and 1 or more lower-quality studies, or in multiple lower-quality studies. And red is that there's insufficient evidence, so there's only 1 study available, or there are inconsistent findings in multiple studies. So this is just an overview of the clinical factors. So don't try to read this. So just look at the amount of factors that have been studied. And this is not, so what we had to do is go from the 482 factors that were reported in studies, boiling it down, classifying it to factors that were comparable, and so we came up with we classified those factors in a group session, and already so this is the classification that we're reporting on. So we're not going to report on the 482 factors that were reported. We're going to present you our classification of the evidence. So if we look at the clinical factors, pain and function, and what we found in the previous review was that radiating pain and functional status and pain scores were supported by strong evidence. In the subacute phase, we actually found strong evidence for no effect of functional status and pain. So it seems to be that in the acute phase it's really important, but if people are away from work for a longer period of time, that influence seems to almost evaporate. But what is interesting is that there's in the subacute and chronic studies, people rely on functional capacity evaluations, so that's the more elaborate testing that's been done in that group. And there's actually 2 medium quality studies that find a positive effect of scoring better on a functional capacity evaluation and return to work.
Just a quick question about when you conclude no effect, is adequate statistical power to be comfortable with that a necessary requirement for a study to be high quality?
It's part of the quality appraisal.
But it's one of the points. It's not. If they get everything else right but have low power, they could still be high quality.
Yeah.
So it could be an issue.
Could be. But I think it has to do with that. You know, if you ask people how they're functioning because functional status is a self-report questionnaire. You don't want to have the more objective evaluation of functional capacity in the same statistical model as well. So they're just using the more elaborate determination of functional status in those studies, because it's often in a rehab setting where people end up when they're away from work for an extended period of time. So, and in the chronic phase, there was one high-quality study that found no effect for radiating pain, but then there were 2 lower quality, so one lower quality study and 2 moderate quality studies that found a negative effect for functional status, so the self-report one. And the same for pain.
The higher the functioning, the more negative the effect on return to work?
So the poorer yeah, maybe I should change, give it the same direction. So if you are functioning poorly, then your return to work, it takes longer.
Okay, what we would expect, yeah. All right.
And this is a better score, so more functional capacity, so a higher score on that test, the more likely people are to get back to work. So it's a little bit of it seems a bit of a U-shape, so it's a little bit confusing what functional status and pain are actually, what the role is of those studies. But again, in the chronic phase, we see that that functional capacity evaluation seems to have the information, the score that you get from that evaluation has a positive effect. So no effect of pain observation, or there's a negative effect in one moderate quality study of pain observation. So that's a clinician looking at his patient while he's coming into the door and see how he behaves, so whether they're guarding, so that's the way they walk and the way they behave. But one lower quality study didn't find that effect in the chronic phase. So treatment. In the acute phase, we found that some providers are more successful in getting people back to work than others. We found strong evidence for no effect of clinical examination. So it doesn't mean that people shouldn't be doing clinical examination any longer, but it doesn't seem to be associated with how fast people actually get back to work. And there was a clear negative effect of the use of opioids on return to work. What we found in the chronic phase is there's a delay in referral that was reported by 4 high-quality studies. It's a little bit tricky because you will always find that people that are away from work for a long period of time and that then get included into a study there's a little bit of what comes first in that factor. So is it because people are away from work longer, or is it because they got delayed, that their referral got delayed? So it's a bit of a tricky factor. In the subacute phase, there was moderate quality that a brief intervention was helpful in getting people back to work, and again in the chronic phase, there's also moderate evidence for the effective intervention. But intervention, the effectiveness of intervention should really be studied in intervention studies. So these prognostic studies more or less reported it, but it's not the highest form of evidence to look at the evidence on effectiveness of certain interventions. But it could still be used as an indicator. If somebody sees that a case is receiving intervention, it might be, if it's the appropriate intervention, it might be an indicator that people are going to get back to work. So some other factors. The acute phase, there was strong evidence for no effect of lifestyle. In the subacute phase, there seems to be no effect of sex, so just putting in whether it's a male or a female. In two high-quality studies and two moderate-quality studies didn't find an effect. There was a negative effect of age in the subacute phase, but there was conflicting evidence for age and sex in the acute phase. In the chronic phase, again, there was a positive effect where males returned to work faster than females, but it was non-significant in one high-quality study. But overall, there seems to be a positive effect of being male on return to work, and there was moderate evidence for a negative effect of older age in 3 high-quality studies, 2 medium-quality studies, and 3 lower-quality studies. But those higher quality studies, the effect was negative, but it wasn't statistically significant. So it's still a little bit tricky. And again, but there's insufficient evidence for lifestyle. But again, that lifestyle factor didn't show up to have an effect on return to work. So if we look at psychosocial factors, this is the overview again, so quite a few factors studied in that domain. The recovery expectations, there's strong evidence for recovery expectations in the acute phase. Not as clear in the subacute phase, but there's still a positive effect. There's just not enough studies out there. And there's one moderate quality study in the chronic phase that finds a positive effect. But there's just not enough studies out there that actually looked at this factor in that phase of disability. But I think the overall picture is really that across phases there seems to be a positive effect of those recovery expectations on return to work. So this is one that was often cited by people in practice. They would all talk about kinesiophobia. So in the acute phase we already found that there's inconsistent findings of fear avoidance and kinesiophobia. There's still, in the subacute phase, there's insufficient evidence for fear avoidance, but there's in one high-quality study there is a negative effect of fear avoidance. And again, in the chronic phase, there's inconsistent findings about fear avoidance and the role in return to work. So there was clear evidence of no effect of pain catastrophizing in the acute phase. There's a negative effect of pain catastrophizing in one high-quality study and a negative effect of pain catastrophizing in one medium-quality study. So it's not as clear as our stakeholders report in the workshops. The same happened when we did workshops on the acute phase. They're all very convinced that kinesiophobia is a really important factor, but the evidence isn't as clear as stakeholders would probably like to have seen. But it's a very influential thing that's very prominent if you talk to people in practice. They all talk about kinesiophobia and pain catastrophizing. I always prefer the pain catastrophizing concept over the fear avoidance. Well, kinesiophobia is an interesting concept, but the fear avoidance concept is always a little bit controversial. So the effect of depression in mental health, we found no effect of depression in 2 moderate quality studies in the acute phase. We find no effect, so we find moderate evidence for no effect of depression in 1 high quality study and 1 low quality study. We got a really interesting discussion going in Manitoba where they said, now if you're away from work and you're on benefits and you have there's a chance that you can actually get cut off from benefits and you're in financial stress, you're quite likely to report depression because you're just really anxious and very distressed. And it's not so much depression, that's just all the worries that come with being in a financial squeeze. So it was kind of interesting to see that that distress was found to have a negative effect in 1 high quality study, and there were 4 lower quality studies that looked at the more global concept of mental health, not specifically depression, and they found a negative effect of a poor score on mental health questions. It's just that those studies were deemed to be not very high quality. An overview of the workplace factors. It's clear that there are some holes in the evidence here, and that's just caused by the lower number of studies in the subacute and the chronic phase compared to the acute phase. If you look at more physical factors in return to work, in the acute phase we found modified duty, so trying to mitigate those physical demands in the workplace, and just having a lower physical demands in a job were positively associated with the outcome. I also put in socioeconomic status and lower education, because I think if you don't measure lower physical demands in a study, socioeconomic status and lower education might be a proxy for being in a job where that's just more physically demanding. So again, in the chronic phase, they find that the 1 high quality study and the moderate quality study found a positive effect of having lower physical demands in the job. So the type of job, in my view, clearly matters. Same in the subacute phase. Modified duties, there's 1 study in the chronic phase that actually reported positive effect of modified duties, but it's not clearly studied in a lot of the other, it's like in the subacute phase. But modified duties could also be considered as an intervention, and if you really want to know if it's effective, you should probably want to do a clear intervention study. And there's some evidence from those intervention studies that modified duties, of course, help. So job satisfaction there was strong evidence in the acute phase, but in the chronic phase there's no effect of job satisfaction in 1 medium quality study. Same for social support and skill level. I think this is it's very logical. So if people are away from work for a shorter, because the question is, overall, are you satisfied with your job? And if you're out of your job for a shorter period of time, your perception of how much you like your job is probably very different from when you're in that chronic phase where some workers could have been away from work for over a year. So I think people can't really recall how they felt about their job, and they probably have a very different perception about their job. But overall, it wouldn't make sense to ask people about their job satisfaction when they're in the chronic phase. But we could still use a few studies to really confirm those findings. So claim-related, suddenly there's a clear, there's strong evidence for 1 factor in the chronic phase, and that's litigation. So there were 2 high-quality studies that showed that if people are involved in litigation, their return to work was much slower. And I started wondering, what if people can't litigate? There's probably a lot of people that would really want to litigate, and it might actually tap into the perceived injustice idea that René Louise Frans and Michael Sullivan have been discussing at the last Work Disability Prevention Conference. So if people aren't allowed to litigate, they might actually still be very unhappy with the process. So in the acute phase, we found some studies that looked at claim-related factors. So it does matter how you organize that system. There was mixed. There wasn't very clear what the role of work-relatedness was in that acute phase, but that's also very context-specific. And in the chronic phase, there was a negative effect of workers' compensation issues in one medium quality study and one lower quality study. But overall, it doesn't seem to be studied that often, so that might actually be something that further research might shed some light on, or maybe look at other conditions besides low back pain. So overall, we did find different factors being studied in the literature that we uncovered. But there still is an emphasis on clinical factors because that's often the setting where that kind of research takes place. People are being sent to a healthcare provider that administers some questionnaires, does some testing, asks some questions, and if they're lucky, or if we're lucky, that actually ends up in a good quality study. So we hypothesized that in the subacute and the chronic phase, those psychological factors and social issues would be more prominent compared to the acute phase. It's not as clear as we anticipated. It's partly because there are less studies than I thought. But recovery expectations and catastrophizing, well, that's not true that it's associated with return to work across phases, because it isn't associated in the acute phase, but there seems to be some association in the later phases. But there's not a lot of studies out there that actually make that link between catastrophizing and return to work. It's often very much it stays within that clinical setting and looks at more intermediate outcomes. So what I learned is more studies does not mean more clarity. I was kind of smart when I did my PhD to focus on that acute phase because it removes a lot of the noise and the bias that you find in the literature. And there's actually the majority of the study is actually done in that acute phase because people have that idea that if we can measure stuff in the acute phase, we can intervene early and actually make a difference. But in practice, people are often on benefits for a long time. So is there more research needed? And first I would say, well, no, but then I'm involved in a study that wants to look at the screening at an early stage and based on the screening identify what intervention is most suitable for different workers. So yes, please. So in the end, 482 factors were studied. So as researchers, we could really more people should do that exercise that we did because there's clearly little consensus of what needs to be measured and how we should be measuring it. So as researchers, we should really shape up. The outcomes that we found in research, successful return to work is still determined by a surrogate measure of time on disability benefits in most studies. So it's what's available, and we're not asking injured workers whether they got back to work, whether they got back to another job, whether they went back to modified duties, and whether they're actually happy in their new job. So what's successful return to work? So a lot of the measures that we found were still based on disability benefits data. So finally, absence of evidence is not evidence of absence. So just because we couldn't find the study that looked at, just because we couldn't find enough studies that looked at catastrophizing and return to work in the subacute or the chronic phase doesn't mean that it's not important. We just identify that there should be more studies done on the topic, and mainly studies that consider return to work as an important outcome. Because that idea seems to be present in people that look at that acute phase. That people that are treating chronically injured workers still rely on more surrogate measures, so that they could clearly do a few more studies using return to work and successful return to work as an outcome. Okay, our next steps. So we'll be analyzing the stakeholder feedback from the workshops that we did in Manitoba. Nelson Aranya in Manitoba is going to be the lead on that. So that feedback will inform future steps and the reporting of our findings. It was interesting to see that there were participants with a very varied background interested in the topic. and what they, in the end, reported to us, but they were very interested in a shared evidence booklet, and with the emphasis that it should be supported by all stakeholders. And then that old paper popped up in my head where John Frank said, well, new evidence gives new hope if we can just get all the players on side. And they want to have something that they can share between the varied stakeholder groups. But I think it's going to be a tough job to actually satisfy everyone with the booklet that we want to collate. So any questions or?
Thank you very much.